In this lecture, we will cover the major concepts of the acute myeloid leukemia, which is one of the most important leukemia. So without wasting time, let's get started. So before starting, we will look at the blood cell lineage. So it starts from the hematopoietic stem cell. It converts into the two lineage, common myeloid progenitor and the common lymphoid progenitor. So it starts from the common myeloid progenitor. It forms three lineage. First is the megakaryoblast that ultimately form the thrombocytes, or you can say platelets. Second lineage is the proerythroblast, and ultimately it forms the erythrocyte, which is also known as red blood cell. These are the platelets. And third lineage is the myeloblast, and that ultimately you will see the formation of promyelocyte, myelocyte, metamyelocyte, band cells, and ultimately you will see the formation of three granulocyte white blood cells: neutrophil, basophil, and the eosinophil. Along with that, you will see from the myeloblast, you will also see the formations of the monocytes, which is a granulocyte. So these ultimately you will see the formations of the white blood cells from the myeloblast. Red blood cells, white blood cells, and the platelets all linked to the common myeloid progenitor. But defect starts from the myeloblast. You will see increased in the myeloblast in the bone marrow, and ultimately you will see that disrupt the synthesis of the thrombocytes and the erythrocytes in the bone marrow due to the increase in the number of the myeloblast, or you can say blast cells. But important thing which you have to remember, in the CBC report you will see the high in TLC count, total leukocyte count. But if you look at the differential count, neutrophil and the other cells will be low, because all cells will stuck at the myeloblast stage. There is no stage towards the neutrophil, basophil, and eosinophil. So ultimately, mainly in majority cases, you will see high myeloblast, or you can say blast cells in that case. There is no differentiation in that case, but in some types there is. Next, if we look at the epidemiology, so it is common in the adults, that is the important thing, and it is slightly more common in males as compared to the females. Next, if we look at the risk factor, what risk factors enhances the AML, acute myeloid leukemia? Chemotherapy and the radiotherapy. After the chemotherapy, there is chances of developing AML, acute myeloid leukemia. Next is the exposure to the benzene. Third is the Down syndrome patient most probably go towards the AML, acute myeloid leukemia. It as the name indicate, acute suddenly happens. And second is the its links to the myeloid lineage and leukemia that is related to the white blood cells. Myelodysplastic syndrome and the myeloproliferative neoplasm can also go towards the AML, acute myeloid leukemia in that case. Next, if we look at the clinical features, fatigue and the pallor. Patient will be fatigue and the pallor due to the decrease in the number of RBCs. RBCs number will also be affected by the increase in the blast number in the bone marrow. Next, bruising and bleeding gums. This happens due to the decrease in the platelets count. The scenario will remain the same. Platelets count will also be low because due to the increase in the blast number, RBC's lineage and the platelets lineage will be disturbed. Recurrent infections, because blast cells will increase and you will see reduction in the differentiation of the blast cells in the neutrophil, and ultimately the infection in the patient will enhances. The chances of the infection will enhances. Hepatosplenomegaly, enlargement of the liver and the spleen, gum hypertrophy in certain types of the AML, and lymphadenopathy, but it is common in the ALL. So these are the important clinical features regarding the AML. How we will diagnose the AML? So we have different methods from the CBC. RBC's count will be low, hemoglobin will be low, platelets will be low, and the white blood cells will be high, or it can be normal, but most probably it will be high in that case due to the increase in the blast. Next, in the peripheral smear, you will see the increased myeloblast, 20%, greater than 20% myeloblast, or you can say blast cells. Along with, you will also see the outs rods in that case, that you will see in peripheral smear. You can also go towards the cytogenetic or molecular studies. You can also see the mutations, like one is the T821 mutation, translocation between the chromosome number 8 and the 21. This is one of the mutation happens in the AML. Next is the cytochemistry. So you can also go towards the MPO, myeloperoxidase stain, that is used against these cells. So myeloblast will be positive in that case because they contain the peroxidase enzyme. Next, you can also go towards the Sudan black B. Myeloblast will be positive, or will be colored by the Sudan black B. So it will be positive in that case. Otherwise, ALL will be negative in that case. Non-specific esterase will also be positive in certain types of the AML. So these are these different cytochemical tests we done in the diagnosis of the AML. Next is the immunophenotyping. You will see the you will detect the markers of the myeloid cells, CD13, CD33, CD117, and MPO. We can detect it through the flow cytometry. This is a technique used in the detection of these markers. Next, in the treatment, inductive therapy, you will go toward the 7+3 regimen. 7 days cytarabine and the 3 days anthracycline. Next, after the inductive, that is the initial therapy, you will go toward the consolidation therapy. In that case, you will see the high dose cytarabines and the stem cell transplantation in that case. Target therapy, in the target therapy, you will see the FLAT3 inhibitors and the IDH inhibitors. Supportive therapy, you can go toward the blood transfusion, antibiotics, and the antifungal drugs due to the recurrent infection in that case, due to the low in the mature or the differentiated white blood cells. Next is the clinical scenario. That is the most important thing, that clear our concept regarding the AML. 45-year-old male presents with fatigue, bleeding gums, and the recurrent fever. Fatigue due to the low in the RBCs, bleeding gums, platelets low, recurrent fever, it means that due to low differentiated WBCs. Next, patient examination, pallor, petechiae formations on the skin, mild hepatosplenomegaly. CBC report shows HB 7.8 gram per deciliter. HB is low. Next, WBCs 35,000 per microliter. WBCs are high. Normal value is 4,000 to 11,000, but it's 35,000 per microliter. And the platelets is 25,000 per microliter. It's low. Normal value is 1,50,000 to 4,50,000 per microliter platelets, but it's too low. So that's why a patient is presenting with the bleeding gums due to the low in the platelets count. Peripheral smear show myeloblast along with the odds rods, and the blast 30%, greater than 30% blast seen in the peripheral smear. And cytochemistry, you will see the MPO, peroxidase positive, and cytogenetics, CD13, CD33, CD34 positive, along with mutation CT, translocation 821. translocation in that case. So all this scenario confirms that patient is presenting with the AML, acute myeloid leukemia, because the symptoms, reports, and the all things confirm that the patient is suffering from acute myeloid leukemia. So this is all about the acute myeloid leukemia, AML. If you still have any question, you may ask in the comment section. Thank you so much.